Welcome back. For the next 6 weeks, we're going to discuss a variety of clinical problems related to the liver. To get things started, however, I think we should review some basic anatomy and physiology. The liver has several ligaments that are of interest to us as surgeons. The first and the most prominent is the falciform ligament. This ligament connects the liver to the diaphragm as well as to the anterior abdominal wall. Contained at the bottom aspect of this ligament is the ligamentum teres, or round ligament, which represents the obliterated left umbilical vein. We routinely divide this ligament during an exploratory laparotomy. We do this so our retractors don't place undue tension on the liver and cause a tear. The second ligament of interest to us is the coronary ligament. This ligament also attaches the liver to the diaphragm and contains an anterior and posterior leaf. The area between these two leaves is called the bare area of the liver and is centered around the vena cava and the hepatic veins. Laterally, the coronary ligaments fuse to become the thickened triangular ligament. You're probably most familiar with the left triangular ligament, since we routinely have to divide this ligament to get exposure to the GE junction. So during Nissen fundoplications or gastrectomies or even splenectomies, dividing this ligament is a routine part of the operation. The liver is covered everywhere except the bare area by visceral peritoneum, which we call Glissen's capsule. This is exquisitely innervated, and distension of the liver from pathologies like hepatitis causes exquisite pain. The lesser omentum encloses a space we call the lesser sac. The lesser sac, in turn, is in communication with the larger peritoneal cavity through the epiploic foramen. The lesser omentum is made up of two separate ligaments. The gastrohepatic ligament is a very flimsy layer which connects the lesser curvature of the stomach to the undersurface of the liver. The importance of this ligament to us as surgeons is that it is through this ligament that aberrant vessels to the left lobe of the liver run. The hepatoduodenal ligament is a much stouter structure, and it contains the portal triad, the hepatic artery, the common bile duct, and then the portal vein. In the left image here, we see the typical arrangement in the portal triad. The hepatic artery is anterior and to the left. The common bile duct is anterior and to the right. And the portal vein is the posterior structure. If you're ever doing an operation that requires circumferential mobilization of the common bile duct, let's say a hepaticojejunostomy for a biliary bypass, one needs to be very careful of this underlying portal vein. It's a very thin-walled structure and doesn't tolerate much abuse. Over here on the right, we see a very useful trauma maneuver called the Pringle maneuver. Basically, you're going to put your finger in the epiploic foramen and come out into the thin, flimsy gastrohepatic omentum. You can then place a vascular clamp across these portal triad structures to cut off the inflow to the liver. This, of course, can be life-saving, but it can also be diagnostic. For instance, if the bleeding from the liver doesn't particularly stop after doing this maneuver, it tells you that there's a retrohepatic caval injury or a large hepatic vein injury. The internal anatomy of the liver can be described in various different ways. We can talk about lobes, sectors, or segments. So let's figure out what we mean by a lobe first. A lobe is a functional unit based on the distribution of the right and left branches of the hepatic artery and the portal vein. What I mean by that is if you ligate the right hepatic artery and the right hepatic vein, you will quickly see a zone of ischemia on the right side of the liver, and the left side of the liver will be unaffected. It would be nice, however, to be able to know what the right lobe is relative to the left lobe of the liver without having to ligate the vessels. The problem is there are no obvious physical landmarks on the surface of the liver to guide us. The only real obvious landmark is the falciform ligament, but that separates the left lateral segments from the left medial segment. Cantley tried to solve this problem by coming up with his line. He described a line from the gallbladder fossa to the inferior vena cava. The problem for us in the operating room is we can't see the vena cava, and so Cantley's line is just a guess and isn't terribly useful to us. Claude Cuno was a French surgeon and anatomist who spent much of his professional life trying to understand and describe the internal organization of the liver. He first was able to organize the liver into sectors based on the hepatic veins. So if we look at the middle hepatic vein here, it splits the liver into a right side and a left side, or sometimes called a right hemiliver and a left hemiliver. The right side of the liver is then bisected by the middle hepatic vein, and it splits the right side of the liver into a right posterior sector and a right anterior sector. The left hepatic vein splits the left side of the liver into a left lateral sector and a left medial sector. The sectors are then divided into segments by the portal vein and the hepatic artery, which generally run transversely across these sectors. So we now end up with 8 separate segments. This picture is meant to show that each Cuno segment contains its own portal vein branch. In fact, a Cuno segment contains its own hepatic artery branch, its own portal vein branch, a draining bile duct, and a draining hepatic vein. So what really is the point of this Cuno classification system? Ultimately, it's designed to show that the liver is made up of 8 independent segments, and that any one of these segments could be resected without damaging the rest of the liver. In the original Cuno classification, the left medial sector was not subdivided, and so it was called segment 4. Bismuth altered this. He wanted to be more consistent with the rest of the nomenclature, so segment 4 is now often split up into 4A and 4B. 4A and 4B certainly fulfill the Cuno requirements to be a segment. Each of these has their own independent hepatic artery, portal vein, and bile duct, as well as hepatic vein drainage. And looking at this picture, you can certainly see how it would be possible to do a resection of an individual segment. Looking at segment 5, for instance, it is possible to just remove this amount of liver and avoiding the hepatic vein for segment 6 and avoiding injury to the portal vein and hepatic artery up here. If you did try to do a segment 5 resection and ultimately injured the portal vein up here, well, then you may well be obligated to do a completion lobectomy. Well, I hope the concept of liver sectors and liver segments makes a bit more sense now. To sum it all up, the 3 hepatic veins split the liver into 4 separate sectors, and the portal vein splits each sector into two separate segments. Each of these segments is an autonomous unit. It has its own hepatic artery and portal vein for inflow. It has its own hepatic vein for outflow, and it has its own bile duct for biliary drainage. And so you could resect an individual segment and not have any damage to the rest of the liver. Is this at all any way important? Well, liver transplant surgeons make use of this when they do a split liver transplant. And in surgery on cirrhotics, this can also be relevant when you need to preserve as much liver mass as possible. All right, let's move on and say a few words about the hepatic artery. This vessel is responsible for about 25% of the total blood flow to the liver and about 50% of the oxygen. One question to think about here is where on this picture could you ligate the hepatic artery and not end up with an ischemic liver? Well, if you placed a bulldog clamp across the common hepatic artery, you will have a palpable pulse in most circumstances at the proper hepatic artery, so you won't get an ischemic liver. There's abundant collaterals through the gastroduodenal, which communicates through the superior mesenteric artery through the pancreatic head vessels. Now, what would happen if you divided the right hepatic artery? Well, this happens more often than you might think in cholecystectomies. And if the patient has an underlying normal liver, you're not likely to notice anything, either intra-op or post-op. Okay? Ultimately, the liver should survive dividing any one of the individual lobar branches. Where this would not be so is if the patient is a cirrhotic, or in, let's say, a patient with pancreatic cancer who's had long-standing biliary obstruction. These patients have very abnormal livers and do not tolerate any ischemic insult at all. The normal hepatic artery anatomy that we saw in the last slide only occurs about 60% of the time, and so it's not terribly unusual to find an anatomic variant. The most common of these variants is a replaced right hepatic artery, which occurs about 20% of the time. This vessel will originate from the superior mesenteric artery. So my question to you is, how would you know if you have a replaced right hepatic artery? In other words, where would you expect to find it? Well, the way to check for this vessel is to palpate the hepatoduodenal ligament. A replaced right hepatic artery will present as a palpable pulse posteriorly and laterally in this position. You will feel a pulse in the left anterior position in this ligament as well, which would correspond to the common hepatic artery, which will then give rise to the left hepatic artery. You need to be careful of this replaced right hepatic artery during a Whipple resection. This vessel is in close proximity to the gastroduodenal artery, and it's an easy enough mistake to ligate a replaced right hepatic artery, thinking you're ligating and dividing the gastroduodenal artery, which is a necessary part of a Whipple resection. Some surgeons, but not all, will do an arteriogram before the procedure to see what kind of arterial anatomy they might have. If you do have to resect a replaced right hepatic artery to successfully remove a resectable pancreatic cancer, then it probably makes sense to do a vascular reconstruction at the same time. Although many livers tolerate resecting a replaced right hepatic artery, the patient with obstructive jaundice has a damaged liver and doesn't tolerate this very well at all. Another arterial variant is the replaced left hepatic artery. In this situation, The left hepatic artery originates off the left gastric vessel, not off the common hepatic artery. This vessel will run through the gastrohepatic ligament. One has to be careful when one's doing a gastrectomy about this vessel. If you're doing a gastric cancer operation for cure, ideally you're going to be dividing the left gastric artery close to its takeoff. In this case, that would mean that you're dividing a replaced left hepatic artery as well. Many patients will tolerate this, but anyone with a degree of cirrhosis might have some problems. Both a replaced left hepatic artery and a replaced right hepatic artery also can exist as accessory vessels. In other words, the main trunks are present and the replaced vessels are accessory vessels to just a part of the lobe. The extrahepatic portal vein brings about 75% of the blood flow to the liver and roughly 50% of the oxygen. Of course, the job of the portal vein is to bring absorbed nutrients from the gut straight into the liver for processing. The portal vein is formed underneath the neck of the pancreas here from the junction of the superior mesenteric vein and the splenic vein. We will have much more to say about the portal vein next week when we talk about portal hypertension. We've already talked about the hepatic veins in some detail, so I just want to make a few more points. The hepatic venous drainage of these interior segments, 8, 5, and 4, is more complicated than the Kuno classification system might let on. In other words, if we look at just segment 8, it has at least 2 hepatic veins draining it. One goes into the middle hepatic vein, and the other goes into the right hepatic vein. Oftentimes, there can be multiple veins going into either one of these middle or right hepatic veins. And the same can be true of segment 4 as well. As far as how these veins enter into the vena cava, the right hepatic vein essentially always enters as an independent trunk. But the middle hepatic vein and the left hepatic vein invariably join up inside the liver parenchyma and form a common trunk. The caudate lobe drains directly into the vena cava. The right lobe of the liver also has multiple veins that directly enter into the inferior vena cava. To do a formal lobectomy requires dividing these veins, and so to access the inferior vena cava, you have to fully mobilize the right triangular and coronary ligaments. These veins are often most conveniently divided using an endo-GIA. And if you ever find yourself doing a right adrenalectomy, this is the exposure that you're going to need. The right adrenal vein enters the retrohepatic IVC posterolaterally, and so to gain access to this area requires full mobilization of the liver. One of the most difficult problems in the trauma world is identifying and repairing a retrohepatic caval injury. To deal with this and to have any chance for patient survival requires totally isolating the liver from its blood supply. This can be done with a Pringle maneuver across the hepatoduodenal ligament, and then the cava has to be isolated with a clamp across the infrahepatic IVC and another clamp across the suprahepatic IVC. To get the suprahepatic vena cava generally requires a sternotomy incision. At the microscopic level, the liver is arranged into lobules. Each lobule has the shape of a polygon, where you have portal triads at the periphery and a central vein in the center. The central vein ultimately drains into the hepatic veins. And so blood flows from the portal vein and the hepatic artery into the hepatic sinusoids. The sinusoids are discontinuous structures, and so the blood spills out of the sinusoids and is in contact with the hepatocytes. The blood is then recollected into the central vein, ultimately making its way to the hepatic vein. The hepatocytes are arranged in cords that are 1 cell thick. And so blood and the nutrients in the blood flow through the hepatic sinusoids. There are large gaps in these sinusoids, and so these molecules can move across the space of Dis, which separates the sinusoid from the hepatocyte. The hepatocyte can then process these molecules as necessary. We'll have more to say about the space of Dis later on because it's relevant when we're talking about ascites production. Another thing to notice is that the sinusoids have a large number of Kupffer cells, and so the liver is a very important part of the immune system. All right, let's now move on to talk about what the liver actually does. The liver is critically important in carbohydrate metabolism. In fact, a very ominous sign in a patient with acute liver failure is hypoglycemia. If a patient has recently eaten, then the liver removes about 50% of the glucose presented to it. It doesn't take all of it because the brain and red cells need glucose as a fuel source. The glucose that the liver absorbs is converted to glycogen for storage, and once the glycogen storage capacity has been maxed out, then ultimately this glucose is converted into fatty acids and then triglycerides and eventually exported to be stored as fat. If you haven't eaten within 24 hours, then your liver glycogen gets all used up. Since your brain still needs glucose to operate, then the liver now has a responsibility to make new glucose. This is primarily going to come from amino acids catabolized from muscle. Lactate, which is a byproduct of anaerobic metabolism, can also be used to make glucose, as can the glycerol backbone of triglycerides. The liver is responsible for cholesterol metabolism. Cholesterol is an important component of cell membranes and is also the precursor to most steroid hormones. In situations of cholesterol excess, the cholesterol is excreted into the bile. The liver is also important in producing phospholipids, and the liver also must produce ketone bodies from fatty acids if a fasting situation lasts more than several days. The liver synthesizes innumerable important protein products. Some of the relevant ones are albumin, coagulation factors, acute phase reactants. In addition, the liver is the principal site of urea synthesis, and in cases of liver failure, urea can be converted to ammonia and result in encephalopathy. Most vitamins require modification in the liver to become active. In addition, the liver is capable of storing some vitamins. Vitamins A, D, E, K, and B12 are stored in the liver. In addition, A, D, E, and K are the fat-soluble vitamins, and they depend on liver bile production for absorption. The liver produces and secretes approximately 1,500 mLs of bile a day. This is under the influence of the hormone secretin. Bile has two main purposes. The first is it's a route of excretion for a multitude of substances, including bilirubin, cholesterol, and a variety of our antibiotics. Bile also facilitates the intestinal absorptions of lipids and fat-soluble vitamins. All of the coagulation factors except von Willebrand's factor are produced by the liver. Factors 2, 7, 9, and 10 require vitamin K to be present for their activation. Since factor 7 has the shortest half-life, we can conveniently use this factor as a measure of the synthetic function of the liver by measuring the prothrombin time, or the INR. The liver metabolizes many of the drugs that we use therapeutically. If you're taking care of a patient who has any element of liver failure, then reviewing their drug list is essential and drug dosages modified as necessary. The liver is the largest component of the reticuloendothelial system. The Kupffer cells, which are fixed macrophages, lie entirely within the sinusoids and therefore are in constant contact with portal blood flow. The job of these Kupffer cells is antigen presentation and phagocytosis. The Kupffer cells are also able to alter hepatocyte function by means of cytokine secretion in response to any septic stimuli. As critically important as the liver is to our health and survival, we have no good way to measure its function. In other words, we have no test or measured value that will tell us whether the liver is operating at 10% capacity or 60% capacity, for instance. As a point of reference, we might look at a patient with renal failure. We can use the serum creatinine to measure a glomerular filtration rate. That patient then can be put in a category of renal dysfunction based on a measured and calculated value. No such thing exists for the liver. So we're forced to estimate liver function. We can use a variety of our liver function tests to sort of gauge problems. In other words, the transaminases are used as markers of hepatocellular necrosis. An elevated alkaline phosphatase or total bilirubin suggests cholestasis or obstruction. Perhaps the most useful marker of overall liver function is the INR. Since synthetic function of the liver is relatively preserved until the end, a patient with a markedly elevated INR is a patient who probably has a very poorly functioning liver. Since we have no way to quantitate liver function, several scoring systems have been devised that function as a surrogate for liver function. The original scoring system was the Child-Pugh score. It's based on two clinical observations, whether encephalopathy is present or not, and to what degree, and the same for ascites. There's also three measured values that make up the Child-Pugh score: bilirubin, albumin, and prothrombin time. You can see the scoring system on this chart. The scores are tallied, and patients are put into one of three categories depending on the number of points they get. This system was originally designed to select patients who might benefit from an elective portocaval shunt. And so its purpose was to figure out who might live long enough that it was worth embarking on a very morbid intra-abdominal operation. Subsequently, the child score was used to select patients, or at least to stratify patients, for liver transplant. In general surgery, the child score is useful because it does predict overall mortality after major abdominal operations. A child class A patient has about a 10% mortality after an intra-abdominal procedure, whereas a child class C patient has a prohibitive risk at 70 to 80% mortality. As you might guess, a child class B patient is somewhere in the middle of that with a 30% operative mortality. So this is in general very useful information to us and help us decide what to do with our patients. And even a child class A patient has a substantially higher mortality than a non-cirrhotic patient. Using the child score as a way to prioritize patients on a liver transplant list has several problems. The first is that the clinical parameters, ascites and encephalopathy, are too easily fudged to get your patient a higher ranking on the list. The second problem is that albumin is not the best marker of hepatic function, since albumin can also be related to malnutrition. The MELD score was developed to deal with some of these problems with the child score. The main point of the MELD score is to predict 3-month survival in patients with cirrhosis. In other words, what's the likelihood that this patient will be alive in 3 months without a new liver? And this score is used to put patients in order on the liver transplant list. It uses just 3 readily obtainable lab values: serum creatinine, serum bilirubin, and INR. In addition to its role in ranking patients on a liver transplant list, the MELD score can also be used to assess risk for elective general surgery, just like the child score. As you can see from this chart, anything with the MELD score greater than 20 is a prohibitively high risk. Here are a few references. Simmons and Steed is an old physiology book that I have laying around, which I still find useful from time to time. Okay, that's it for this week. Next week we'll talk about portal hypertension.